Excuse me. Hi, I'm John Santapietro. I'm just going to be saying a couple of words and then passing it over to you. Testing. Great. Excellent. So hello, everyone. Welcome. I just wanted to say a couple of words. I'm John Santapietro, Dr. John Santapietro. I am the Chief Clinical Officer of the Behavioral Health Service Line of Carolina's healthcare system. And we are delighted to be partnering in this conference. Really want to thank the Atlantic. Really want to thank the Aspen Institute. It's been an amazing conference so far. As a psychiatrist, I pay attention to the way that people talk, and I feel the dialogue has been really wonderful. Dialogue is really about people suspending their beliefs for a time so that they can actually listen to each other and have something come out of it, out of that dialogue that's different than when people started. Just want to tell you a couple of things before we get started with the panel about Carolina's healthcare system. We're a large, integrated healthcare system in the Southeast, so North and South Carolina. We have over 40 hospitals in North and South Carolina and 900 care locations. We did 11 or 12 million patient encounters last year, so it's a big not-for-profit healthcare system. And we really believe that at the core of healthcare is an enduring relationship with the patient that spans a continuum. So we have a system that provides care from reaching into the community outreach, to primary care, to hospitalization, to post-acute care and home care. And this panel is particularly exciting to us about prevention because we see prevention as a cornerstone to healthcare in especially the new healthcare environment, and both in terms of population health and but also in terms of cost. Just a couple of words about what we're doing in prevention. In primary care, we have a big initiative for diabetes and prediabetes, screening 50,000 people this year online, getting them in evidence-based practice after that. And then in my world, in behavioral health, we are doing quite a bit in the community, reaching into the community, teaching mental health first aid to citizens of the Carolinas and community members, people in schools, first responders, and also doing quite a bit integrating behavioral health into primary care, which is really all about prevention and catching things before they reach a crisis. So I have nothing else other than I really like it here. I've never been to Aspen, and I don't know if they need a psychiatrist here, but I've been telling my wife that we may want to think about moving. Anyway, this panel is incredibly esteemed, right? Incredibly esteemed panel. You're going to have an amazing time. I'll be sitting right there, and I'm going to pass it over to Julie.
Thank you. I really like it here, too, by the way. I don't know if I'm a journalist in residence, but I could volunteer. Thank you very much for being here this afternoon. This is my third panel of the day, so I'm hoping to keep the energy up. We're here to discuss something that's at the very heart of this conference, I think, and that's the case for prevention. Whoever put together the blurb for this panel put it much better than I could. The problem with prevention is that when it works, nobody really notices. But that said, prevention is really, really hard. It can be expensive, for one thing, and we'll get into that. Buy-in can be difficult from the community, from patients, and from actual providers of preventive interventions. And, you know, compared to a fabulous new drug or treatment or medical device, prevention just isn't all that splashy or sexy. So we're going to explore exactly what it takes to make prevention work. And with us to do this is a really extraordinary panel of people who practice prevention in a variety of ways. So here's what we're going to do. I'm going to introduce the panel very briefly in alphabetical order. We've had one change. Unfortunately, Cyndi Lewis is ill, couldn't join us, but Derek Yock, who was just with me on my previous panel, has graciously offered to fill in, and he doesn't know this, but if he hadn't offered, I was just going to drag him along. Anyway, their fuller bios are in your programs and on the website. They are much more impressive people than I can describe here. Each of our panelists will give a short, very short, I have made them all promise, introductory statement about what they do and how they practice prevention. Then I will ask the panelists a few questions, and then I will open it up to you, whose questions I'm sure are even better than mine. So with that, we will get started. Our first panelist here in the middle is Esther Dyson. She's well known in the world of IT and other tech startups as the founder of Adventure Holdings. More recently, she's founded something called the Health Initiative Coordinating Council, or HICCUP. I'll let her explain to you what that is, but I promise it's really cool. Dr. Howard Koh, next to Esther, is Assistant Secretary for Health at the U.S. Department of Health and Human Services. He was previously a professor and associate dean at the Harvard School of Public Health, and prior to that, Commissioner of Public Health for the state of Massachusetts. David Reese, here on my right, is president and CEO of the East Durham Children's Initiative in Durham, North Carolina. He's also the co-chair of the Partnership for a Healthy Durham and vice chair of the Northeast Central Durham Leadership Council. And finally, all the way over there, Derek Yock is executive director of the Vitality Institute. He's been senior vice president of global health at PepsiCo, head of global health at the Rockefeller Foundation, professor of global health at Yale, and executive director of non-communicable diseases and mental health at the World Health Organization. So quite a panel we have with us, and we will let Esther Dyson lead it off.
Okay. To be totally candid, I forget, is it 2 minutes or what?
What did I think I said? A long elevator speech, so
Okay.
2-3 minutes.
Yeah. I started something called HICCUP when I was about to give a talk saying that somebody should do that and realized that was a lame talk. So I appointed myself. And the basic idea is a lot of prevention is kind of like, I don't know how many of you remember somebody peeing into a reservoir a few months ago and they drained the entire reservoir. It was crazy because actually that has no impact and birds do it as well. But so our idea is to find 5 bathtubs and pour rose water and beautiful liquids into them and actually have a visible impact. So HICCUP was rebranded as the Way to Wellville by our wonderful CEO who comes from Cigna. And we're looking for 5 communities. We have 41 who applied. We're trying to winnow it down, which is painful, of under 100,000 people who already have social capital, cohesion, and interest in improving the community's health. But they're small. They lack resources. They're not connected to the Vitality Institute or the Health and Human Services, or they don't know how to go to Walgreens and say, would you like to test not selling cigarettes in our town? So we're going to help them reach out, but it's the communities doing it themselves. It's not a nice white lady from New York telling people how to live. It's collective action locally, making their own town a healthier place. And then we want to do 2 things: collect data up the wazoo, spread it widely. We hope we get widely copied. And second, a cheesy TV show, lots of PR. We want these places to be proud of what they're doing. We want them to be recognized. And again, we want prevention not to be something where you can do regression analysis and see that there's a small impact on such subpopulation. But my gosh, the whole town is exciting. The kids are graduating from high school. The employers are moving in, et cetera. Obviously, we haven't done it yet, but that's the goal.
Dr. Koh?
Julie, thank you very much, and I want to thank the organizers for this wonderful festival, and thank you everyone for being here and showing your commitment and interest in prevention. I've had the honor of exploring these issues for decades in various roles, now as the Assistant Secretary for Health, trying to help make our country healthier. But my perspective has been basically shaped by my clinical experience, taking care of patients for over 30 years. And very early on in my medical career, I saw too many patients suffering, preventable suffering, and even dying preventable death. And when I saw that time and again as a physician and provider, it was a source of tremendous anguish for me, personally and professionally. And I kept asking, what is a better way to keep people healthy instead of seeing them fall to and succumb to these preventable conditions? And so that's, in many ways, my path toward public health and policy. And I think another very basic theme to convey in a meeting like this is that you have to start with the premise that our good health is a gift, and it's precious, and it's fragile, and we can't take it for granted, either individually or as a nation. We have our health today. We hope we're going to have our health tomorrow. And the only way to protect that very fragile and precious gift is through prevention and public health. So over the years, this interest has risen for me and led me to my current post. And through that, I've had the privilege of meeting so many people like yourselves who are committed to making a contribution to prevention and public health in many, many different ways. This is a forum where we can ask two basic questions to open up a panel like this. One is, how do we track our progress on health and prevention as a nation? And secondly, are there some big opportunities for us right now to advance prevention and public health in some substantial ways? And in response to those two questions, for the first one, I can say that we've had in this country for now 4 decades a goal-setting process called Healthy People. Every decade we set goals and objectives for the country to try to make our country healthier in various topic areas, and we have indicators to track our progress. As the Assistant Secretary for Health, I had the great honor of unveiling Healthy People 2020. I like to say that we need 2020 vision for a healthy people. And this week in JAMA, the Journal of American Medical Association, we have a little report, a report card on progress for Healthy People 2020. And if you look at it, you see that the country is making some progress in key areas like some clinical preventive services like colorectal cancer screening, environmental air quality because of the Clean Air Act, in tobacco, which is critically important, but we need much more progress. Then on the flip side, we still have key areas where we are not seeing progress. In fact, things are going the wrong way, mental health being a major area. So that's one set of topics that we can discuss for this session. And then with respect to opportunities, we have, of course, the absolutely historic opportunity, the Affordable Care Act, which was signed into law in March of 2010 by the President. And I'd like to say that the Affordable Care Act is not just about better insurance coverage, but also about better care and better prevention and public health. Till now, the discussion has been almost predominantly on the insurance coverage aspects, but there are many aspects of the Affordable Care Act on prevention and public health that we can discuss through this forum.
So thank you. Thank you all for coming and spending some time with us. You know, prevention, I think sometimes we take it for granted. I think we take a lot of things for granted, and this is, I think, one of those topics where it just requires us to stop and pay much closer attention. We've created the East Durham Children's Initiative. We started asking this question in Durham, North Carolina. If we were going to change outcomes for kids, socially, as well as health outcomes, academic outcomes, what would it take? And so we decided that we would model the Harlem Children's Zone. We would take a geographic area, about 120 blocks, 1.2 square miles, and we would take an area that had the lowest performing school, elementary school, middle, high, highest rates of teen pregnancy, highest rates of childhood abuse and neglect, some of the highest rates of crime, highest rates of obesity. So there was a theme here. But this was part of this, I think, this community collaboration of, we're going to change outcomes for kids. What should it look like? What should it be? And then there was this other question which we asked, and what really wasn't a question, but it was a thought process of, don't think money. Just think, what would it take? What would it look like? So if we're going to change outcomes, and we're going to have kids who are going to be performing well in school, who are going to be healthy, who are going to be in a healthy community, in a healthy environment, how could we create it as a community? And this last piece to it, I think, was also, how could we create it so that it could be replicatable? We spent time with Jeff Canada in New York from the Harlem Children's Zone. I'm pretty sure many of you have know Jeff, have probably heard him speak before. And we brought him down and we said, hey, Jeff, how are we doing? He said, you're doing pretty good. He said, everything's aligned, so it's not just sort of happenstance, but it's coordinated. So he gave us a seal of approval, and then we said, but we think we have this replicatability component to this process so that we can create this using existing resources from back within communities, address all of the different disparities back within communities, but then pick this model up, drop it in other parts of Durham, but then also drop it in other similar-sized cities across America and begin to achieve, I think, the goal that all of us look for and want, especially as you think about prevention, which is children doing well, who then become adults who do well, who then are just these pillars of our community as a whole. So I'm going to stop there because I'm hoping that you have a lot of questions. That's a hint. a lot of questions. But before I do stop, the key to this is collaboration. And this is not owning it, but also then opening up the door and saying, if we're actually going to talk prevention, we're actually going to talk change, if we're actually going to change communities across our country, well, then how do we open up the door and have everyone else at the table? I think that's part of what makes Durham great. I also think that's part of what makes our country the country that it is.
Good. Derek?
Yeah, I think one of the most powerful statements that has always driven me to think about prevention more deeply was by Bill Foege, one of our great public health people in this country, head of CDC, who said, we tend to let the urgent crowd out the important. And that's at the clinical interface. When you have a sick patient in front of you, you're going to do everything to address their needs. It happens in a policy environment where there's a demand for curative care. And it takes enormous political courage and strength to actually say there must be a limit placed on the curative load because it's endless, and actually put money into prevention. This country, unfortunately, has not done that well. And the result is 97% of healthcare dollars in the federal system spent on treatment and care and 3% on prevention and public health. It's worse in the private sector. About 98 to 99% of healthcare or health-related dollars spent on care and treatment and less than 2% on prevention. So we dug in through a commission, which I would love you to take a look at our website, www.thevitalityinstitute.org. And under the chair of a very unlikely head, thanks for that, Victoria, Will Rosenzweig, who's actually an entrepreneur who brought us a whole range of healthy foods and products and included people from the public sector, Jeff Levy playing a key role in the prevention task force work, the Robert Wood Johnson Foundation, the Clinton Foundation, but the corporate sector as well, Microsoft, Qualcomm, IBM, Humana, folk from the investment community, not the usual likely bunch. And they really came up with a bunch of recommendations, and I'm not going to go into them. But the first thing they said is that this is unacceptable. We really need to start changing the balance, and we can't do it by more rhetoric and discussion and action. We need to do it through very focused work. So the one example is in the workplace, where we put a lot of effort. It's very clear there's underinvestment in prevention of a large scale. Part of the problem is that the visibility of employee health is never made obvious in the annual reports of a CEO. So one of the recommendations is that while we've seen environmental reporting, governance, and diversity now appearing in the integrated reports, financial reports, going to the SEC or being used in the Dow Jones Sustainability Index, we believe that the most important source of human capital, in a company, is its employee base. That's where all the productivity, all the innovation, all the morale comes from. Yet if you don't measure it and report it and do something with it, you're not going to invest in it adequately. And that's going to be a long-term effort, but many companies have already said, we're going to start working with you, and reporting bodies have said the same. The second big recommendation relates to prevention science. And so we did a thorough review of the NIH focus on research and really came to the conclusion that there was severely underspending on prevention as an enterprise, not surprising to many of you here, but that there were opportunities. There were the opportunities of the Affordable Care Act and many of the new funding provisions. There's the opportunity of a new Office of Prevention. And there's one huge untapped opportunity, and that is that the private sector, whether it's in the IT, software, activity, device, entrepreneurial world, are actively realizing that the future of long-term business lies in this nexus between profitability and health, and are investing big time in that. And we see the chance of a partnership like never before to spearhead more investment in prevention science, which could start tipping the balance.
So let's talk just for a minute about exactly what it is that we're talking about and what prevention is. Who wants to take a...
Well, there are really two things. I have this notion of it's not actually protecting health as much as it is producing it. Health is something active. It's resilient capacity. It's, if you have no stress at all in your life, you don't learn how to handle stress. So it's the condition where stress makes you healthier because you deal with it and you get stronger. Like exercising. So for me, and I hope for the HICcup communities, probably the most important thing is really boring. It's eating right. And that's not give everybody a Fitbit and a calorie counter. It's change the food supply. There's a lot going on, as some of you heard this morning, about school food. That's a great place to start. It's a huge market. Even though you'd think the kids have no choice, they actually do. These schools are trying very hard to make food that the kids want to eat. And if you learn how to do it with kids, and if you learn how to do it in the test markets that Way to Wellville is going to offer, maybe you could do it everywhere. There's a lot about marketing and so forth and so on, but food is one, exercise, stopping smoking. Just another little anecdote. This morning, many of you heard about Real Age. The guy who created Real Age, his name was Charlie Silver. Anybody know what business he was in before Real Age, which is like a preventive health quiz kind of thing?
You might explain what Real Age is to people.
Yeah,
who
it's a website where you answer a quiz. Not only do you eat right or do you take medicine, but do you argue with your spouse? Do you have a dog? Are you, all the things that actually really matter around health.
It tells you how old you theoretically are.
Yeah, thank you, Julie. Sorry. And it's a preventive maintenance kind of thing. So Charlie Silver's previous business was a chain of quick oil change shops that he sold to Jiffy Lube. And we probably spend relatively much more money maintaining our cars than we do maintaining our bodies, including probably de-maintaining them by the food we eat. So that's what we're talking about.
But our cars at least tell us when it's time to go get the oil
Well,
changed.
so does your body if you start to ask it. And one of the biggest things I think that's going to happen over the next 5 years is going to be non-invasive glucose and other blood testing so that you can, it takes too long to see the impact of hard living.
Yeah, right.
But that's going to change.
So from our perspective, and I say our perspective, I think about this a lot of times for us it's hands-on with children, hands-on with families. And, we're so very fortunate that we have a public health director back in Durham who continues to promote this concept of prevention without actually saying it's prevention. And I think that's the key, right? Because we want people to actually think about what the long-term outcomes will be, what I want long-term without thinking about what I really need to do right now that may not feel or look very good or be as appealing. And so for us, this is really about culture change. This is about lifestyle. I think that term is often overused, and we say, well, it's culture change and it's lifestyle. But it honestly and truly is. It is when you take communities and you introduce communities back to walking trails. Well, we take this for granted in so many places across the country. Well, in so many other places across the country, you never actually hear or think about a walking trail because your community really isn't safe enough to go ahead and walk. But walking back within communities and creating these amenities, which we sort of don't think about, it just becomes part of what you do, it's part of what your lifestyle is for us, as we begin to think about, that begins to define what I think prevention is, and then what prevention can be. Back in our target elementary school, we chose this school. It was the lowest performing school in the district, and I'm talking low performing, 34% overall composite proficiency and end of grade test. And so people often think about this academic piece, and they look at health, and they say, well, I don't see a correlation. Well, not any of you, of course, but the rest of the world. And, there is this huge correlation between the health of this community and then how kids will get to school, how often kids will get to school, how kids will perform based upon all of the other health-related challenges that are prevalent back within their community. So as we think about prevention, I think, in a myriad of ways, which sometimes may be very traditional, but in other ways are, I think, very, very innovative and very creative.
I would say traditionally we think of clinical preventive services aimed at individuals, so a doctor or a provider is telling you about screenings or about tobacco cessation or obesity counseling and those sorts of issues, and those are all very, very important. But in this day and age, we're thinking much more about prevention activities in the community where people live, labor, learn, play, and pray. That's a line I made up, so I'll say it again. Health starts where people live, labor, learn, play, and pray. So much more, we're thinking not just about health in a doctor's office, but health in a community. So that's where healthy homes is a key theme for prevention. Worksite wellness, Derek just mentioned. Schools is a place for not only education about health, we say that kids need to be healthy to learn and also must learn to be healthy. But we have this great example that we've already heard mentioned about healthy school lunches now through the activities of this administration that affect some 32 million school kids in over 100,000 public schools. And then places of worship can play a big role. And then, of course, we need the environment to support healthy choices. So this is an era where we're talking about prevention with all sorts of new partners. And it's very, very exciting to go well beyond the health sector and talk about making prevention come alive for everybody.
And there's a WHO definition of prevention, isn't there?
I love that definition, and if I can say it here, WHO defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And that means that preventing disease is one thing, but achieving your highest attainable standard of health, not just physical health, but emotional and social well-being, is critically important. So we're trying to think about the health of the whole person, the health of the whole community, link that to individuals, of course, and invite everybody to be involved.
Yeah, I think all I could add is to say that but it was over 25 years ago that the sort of slight counterpart to prevention, health promotion, was discussed in the Ottawa, what became the Ottawa Charter on Health Promotion. And the core message that came out of it was that the goal of health promotion was to make easy choices, the healthy choices, the easy choice. And that involves doing everything that Howard and Esther and colleagues mentioned, but it involves something else. And you started hinting at the non-health sector role. And that's where we basically are failing ourselves. At the moment, we see that cities are designed to remove mobility. The agricultural policy is designed to promote unhealthy eating and obesity. Our educational system, in the rush to promote educational standard, eliminated physical education virtually across the entire country. And yet all of those would have had bigger leverage effects on preventing and maintaining health than almost any clinical intervention you can dream up, maybe outside of vaccines and tobacco control. And the problem is that the folk in health are often not the best advocates to go and tell somebody in agriculture or in urban design. I was in a meeting yesterday down the road in Denver at the Clinton Global Initiative, where one of the most exciting things I heard was when the American Society for Interior Design, who focus on thousands of interior designers and architects, said they are developing guidance on how to design for health, how to design their buildings to maximize movement, to make sure that light and sound and healthy food are part of the design phase, minimizing the environmental exposures. Their impact, can you imagine what that'll do in terms of quietly, without bringing in complicated clinicians, could design the places where we live and work and where we recreate that would be transformative. The same is needed in transport. We had one of the consultations on this down in Atlanta, where many of you are aware of the extraordinary infrastructure development around Atlanta that is regenerating both poor urban communities, but it's making them safe and people are starting to walk, they're starting to invest, the health is improving. The same has happened around the High Line of New York, making the point that large infrastructure programs developed not necessarily because the primary reasons are health, have huge positive impacts on health if done right.
You know, I think there's been, all this focus on the Affordable Care Act. Everybody's thinking only about the exchanges and the insurance expansion. There's an enormous section about health promotion and prevention. I wish you would talk about that a little bit, because I think it's been completely ignored
Sure.
by most people.
We're very excited about the transformative potential of the Affordable Care Act on prevention and public health. And we can summarize by saying that there are many opportunities for prevention for individuals, for communities, and then for the nation at large. For individuals, I hope everybody here knows that health plans are now largely required to cover high-value preventive services, removing cost as a barrier. And the president has already cited the figure that over 100 million people now have access to high-value preventive services, tobacco counseling, immunizations, obesity counseling, other services, without added costs. So And we see that from private insurance and public insurance. So that's absolutely enormous. For the person who says, oh, I can't get colorectal cancer screening because it costs too much, the plans are now largely required to cover that preventive services. So that's great. At the community level, there's been tremendous funding going through the CDC to community prevention grants, so-called community transformation grants in the past. And Recovery Act also funded similar activities to try to get communities like David's working together. And then on a national level, we have now a new prevention fund. Hopefully everybody knows about that now in its 5th year, up to $1 billion a year, a prevention strategy, a prevention council that's advising. So that's all good news, but as we've all already acknowledged, none of this is easy. And everybody has the tendency to take it for granted because prevention doesn't have the dramatic impact that treatment does. And my response to that is that we have to be keeping this progress moving forward. And in the Affordable Care Act, I should conclude by saying there are now lots of funding for pilot grant proposals, mostly through the Centers for Medicare and Medicaid Services Innovation Center, to try to demonstrate that joining the clinical world and the community prevention world together can lead to better outcomes and improve quality and lower cost as well. So if you're looking for innovation to make prevention come alive and also save money, which is a hugely important question, and demonstrate return on investment, those pilot grant application opportunities are very, very important. And all of this has been made by the Affordable Care Act, and we're very, very excited by it.
It's worth adding. My sister's a cardiologist, and so I'm slightly cynical. Not only are these preventive screenings and counseling free to the user, but the doctor gets paid extra for doing them. And I've had people come to me with apps that help the doctors go through the, if you like, preventive care interview, which they can then bill a nice amount for, and that also helps make it happen.
There's a general movement, you've heard this theme throughout the spotlight, of trying to move toward value-based purchasing, not reimbursing through CMS just for volume, but for value. We're trying to get the IT dimensions to help with public health aspects of screening and checking on risk factors and those sorts of things. And we hope that over time that everybody will be more aware of outcomes and the role of prevention to get people as healthy as possible, reaching that highest attainable standard of health.
You've sort of anticipated my next question, which is that I come from, green eyeshade land of Washington, where, with kids, it's pretty clear that there's a payoff to prevention. You get kids healthy, they grow up and they're more productive, and that's easy. For adults, a lot of primary prevention, particularly on the clinical side, doesn't seem to pay off for a lot of perverse reasons. You get people to quit smoking, they live longer, they collect their Social Security and their Medicare, they die of something else, they're more expensive, the CBO says it. So, prevention literally doesn't pay from a federal budget point of view. How do you overcome some of these, perceptions that prevention is a money loser in some cases?
So one of the things in the report, we actually challenged the CBO, and I was on a panel, very peculiar panel. It was of the International Actuarial Society, where we actually had a panel with the people from the Chief Actuary's Office from the CBO. And he presented that kind of data. And first thing I reminded them was that many years ago, Philip Morris went to the Czech Republic on the verge of when they were going to increase the taxes on tobacco, and produced a study which showed that this was not a good thing, because if people lived longer, they were going to incur greater healthcare costs, and the country would be worse off. So let them die. So now we're hearing,
these studies.
I think incorrectly quoted from the study, I'm afraid, Julie, that I challenged the CBO to actually have the same philosophy as Philip Morris. In fact, the long-term projections don't make that point. They say that over the 60 to 70 years, that was of the study, which I think was the first CBO study to ever go beyond 10 years, they showed that there would be a virtually neutral effect, but there would be a huge revenue uplift, and there would obviously be a societal gain, which goes to the question of how you value health, which is an economic decision. If you change the valuation of health, this could turn out to be a huge win for society. And these are human decisions we make. So when we hear stuff coming out of the CBO, I can tell you the problem with prevention in this country is that the CBO chief actuary has said on the public record that they do not believe that the evidence on prevention is strong enough. When they say that, look in the public record, when they say that, the implication is that they score prevention services and those parts of the federal government involved in prevention, like CDC, far lower on the scale. Now, Howard can't say that, but I can say this is a scandal. And I think it's driven by decades and decades of organized efforts by the treatment and care folk to get the limelight and get us to where we are, 97%. This is not the same in other countries around the world. It's not the same in Europe, for example, where the spend on social and preventive services is dramatically above what the US does, which helps us explain at much lower levels of health care, they're getting far better health gains. So I'm thrilled you mentioned the CBO because it's so arcane to us to think about prevention and we're trying to go about our daily lives and eat healthily. Why should we bother about the CBO? We should bother about the CBO because the constrictions they have on the time period they use and the way they do their calculations has an impact on all of our lives.
And I've seen this much to the frustration of lawmakers, Democrats and Republicans. This is not a particularly partisan issue. In fact, prevention is a very much bipartisan issue on Capitol Hill, who cannot get things through because they cannot get it scored by the CBO.
Yeah.
Yeah, I mean, the other thing they seem to be missing is, and ask any employer, the employers are the ones who are leading the prevention because they want healthy employees. They know how expensive it is, and they also know what it's like to have an unproductive employee. And an unproductive employee is also probably not a very good parent, is more likely to get into car accidents. So there's a lot of costs beyond direct medical costs to bad health, including people's lives.
All right, I think we're going to open it up to the audience now. If we can bring the lights up just a little bit so I can see who's got their hands up. And I think we have microphones going around, do we not? Or are we just going to, yes, down here in front. And if you could tell us who you are, that would be great.
Sure. Hi. It's too close. My name is Busha Kalkan. I'm an urban designer from Atlanta, and I ride the Beltline to work every day. Very happy to have that. As an urban planner, and I'm originally from Turkey, when I look at our country, I see that since 1926, when zoning was enabled, we've been building our cities differently than we've been building for 2,000 years. We've created an infrastructure that discourages walking. And for me, the problem is much more endemic and infrastructure related than just building trails. The challenge that I see is these are codified in our regulations, zoning, which is part of my work trying to battle that every day. But how aware, I would ask you, is the community on prevention on the impact of zoning and some of these regulations in affecting the shape of the places where we live and work?
Maybe I can start with answering it from a local perspective, and then you can move to a national perspective. From a local perspective, in Durham, we have what's called the Partnership for Healthy Durham. And that's exactly what it is. It's the folks who come together who say, you know what, our city isn't designed to promote health. There aren't bike trails. There aren't the bike pathways. There aren't sidewalks. Right? We want a healthy city. We want healthy residents, but we don't have sidewalks. Go figure. But this is part of, I think this is a multifaceted approach. One is the redesign of cities. The second, though, is this engagement of community. And community coming together and getting very creative. And this is where we value innovation, right? That's what Americans do. We value innovation. Well, this is part of the innovation. The innovation is, well, how do we achieve some of these goals when we know what the infrastructure, the limits of the infrastructure are? And so I think it's open streets that happen around the country. I think it is trails. I think it is folks coming together and then lobbying policymakers to say, you know what, we need more sidewalks. So I think from a local perspective, that's the way that we've approached it back in Durham County. But I'd love to hear it from other perspectives.
I'll just add a couple of things. There was a transit, Gabe Klein this morning with a T-shirt with 4 lanes that have 3 bike lanes and 1 car lane. But it's not just bikes. Transit is tremendously important because not only does it enable people to walk, especially people who don't have cars to get to their jobs, so it improves the economy, reduces the amount of pollution. I'm trying to, maybe somebody here is an investor in Lyft, which is the peer-to-peer version of Uber. There's a lot of people with cars who could drive other people around. And that would, again, it would raise employment. It would help the other people get to their jobs or to their food or to their doctor's appointments. There's a lot of latent capacity in a lot of places that just needs some local spirit to unleash it.
So the question you asked is hugely important, and we have a very exciting initiative to address that squarely. Everybody here has heard of the First Lady's Let's Move initiative, but there are multiple what we call sub-initiatives. One that we're very excited about is called Let's Move Cities, Towns, and Counties, where we reward mayors and local leaders who really try to make their cities and counties as healthy as possible, not through better nutrition, not just through better nutrition, but also making their physical environment more conducive to recreation and physical activity. So if you go on the National League of Cities website and look for Let's Move Cities, Towns, Counties, we now every year have a ceremony where we honor the mayors who have made the most progress in reaching these goals, a major goal being exactly what you just said, to create a more hospitable physical environment. And we have now given and honored over 400 mayors that cover, I think, about 70 million people in the United States. So this is one way where we work together as national and state and local leaders and really recognize local leadership. Everybody likes to be honored for their initiative, and this is where mayors from across the country can really get recognition they deserve for making their communities healthier.
Just two comments on that. First, I'm thrilled we have you here. I think that having town planners, designers, and architects lead on health and thinking about health for design will have huge leveraging effects. I think if we look at the last decade and a bit of New York City, the transformation on the environment, on the walkability, cyclability, in addition to everything else related to health, the proof is in the results, showing that the city's showing the best improvements in life expectancy in virtually every measure of health outcome, and it shows that sustained, serious leadership and effort can actually make a difference. The other comment is that all of those are public sector-driven efforts. I don't want to put anybody on the spot, but I have my colleague Caitlin from Nike with me here, and I'm aware of the extraordinary work that Nike is doing in trying to actually show that the private sector leadership in trying to promote urban design in ways that are going to facilitate it. And while it's critical in this country, and I think there's a lot of signals of real hope, as Howard pointed to, if we're taking the global perspective, anybody who visits China on a regular basis becomes all too aware that mobility is being engineered actively out of the cities. And colleagues from this country have documented the fastest collapse of physical activity ever seen in recorded history is happening in some of the fast-developing cities of Asia, with dire consequences for social cohesion, for health, for all sorts of other things. Reversing that trend is going to be a big lift, and it's not going to come by the health people advocating from it. It's going to come from the town planners, the architects, and the folk who realize that there's going to be investment opportunity and benefits down the line for the people.
Who else? Right here.
Hi, I'm particularly concerned about the at-risk populations. So I live and work in Detroit and Flint, and top of the list of at-risk communities. And the question I have, we see it as there's no access to good food desert in some areas. There is no good marketing for eating and wellness, right? They don't market it the same way that PepsiCo markets their other products. And then finally, there's no stick, there's no punitive side to a bridge card holder who goes and takes that food stamp bridge card into a convenience store and buys nothing but junk food, which happens every day. So how would you address those three areas: access, marketing, and the stick?
So, and this may be good from a local perspective in terms of what we've done. And so we have a campaign through Partnership for Healthy Durham where we have a healthy checkout aisle. And so it creates incentive. And the goal and thought is that it will create incentive among small grocers to have an aisle which then has only healthy items. And we know how foods are marketed, right? You think about Halloween, right? All the Halloween candy is this high, so all the kids see it. I mean, it's just marketing 101. So there's the coalition work. I think that locally that has to happen that way. I think there's also this incentive piece. This incentive, and I talked a little bit before about culture change. This is this incentive to change culture because there is financial gain back in changing some of the culture and changing some of the health outcomes here. Part of that culture change also has to come back from, I think, city leaders, which we've been very, very fortunate in terms of having that message come from our public health director. So that we went to smoke-free zones. So that then we went and actually had this huge push to have walking, and we discount walking. I don't know why we discount walking. I mean, but this walking piece is critical because there are no sidewalks, especially in small town America. Very, very small, very, very few sidewalks. And then there's this other piece of coming back to our most precious resource and making the case for this. When we started working back in the EDCI zone, our obesity rates amongst our kids were amongst the highest in the city, and they were increasing. Well, last year we had our obesity rates plateau amongst kids at the school at 51%, higher than the national average, higher than the local average, but it's plateaued. This is part of this culture change component in which we have kids, teachers, parents, community thinking about how they live their lives differently. And it's not just community from within communities that we're trying to affect, at-risk communities, but from this larger perspective of community, because there is long-term gain for communities looking to thrive 10, 15 years down the road. And I know that's very, very difficult for elected officials to begin thinking about it from that perspective. But that's part of this culture change component. So I think it can happen on local levels. I think it does happen on local levels. But I also believe that it is, it's not easy, because if it was easy, guess what? It'd be done.
So we're facing an interesting challenge. We can't demonize the food companies. They, one way or another, we want to help them become better. And so at one end, we want to use PR and pilot programs and work with them in our communities. But at the same time, we want our community members to understand how they're being manipulated. And then not, again, to demonize the food companies, but to say, well, we can manipulate ourselves better. We can manipulate ourselves to think long-term. We can do everything from subsidize healthy food to we can have apps that help us see what in the supermarket is good for us or what is bad for us. We can change our culture. We don't need to have somebody else do it for us. With that understanding, we can self-manipulate more positively. One of the fundamental issues here is thinking long-term instead of short-term. As someone said earlier, what do you want to be in 10 years? How do you get there? Rather than focusing on instant gratification, it's hard. Mm-hmm. But if you change what surrounds people, if you change the social norms, if you change where stuff is in the grocery store, if you work with the food companies to get healthy menus that actually taste good, it gets easier.
I think just to answer, one question directly, which is regarded unfortunately as contentious, but shouldn't be. Your last point, I don't see why we continue to spend federal dollars on food programs that aren't with unhealthy food products. We can define very clearly what are healthy food. The nation has done it for WIC. The same logic should apply to the food stamp and SNAP programs. That would obviously, the companies would transition. They will complain until finally somebody has the political courage simply to do it. And they will adjust, and they'll make up the sales somewhere else. Look at CVS taking tobacco out of their store, and what happened? Their share price went up, didn't go down. People are attracted to positive messages. Inside our own company, on a worldwide basis, we explore another approach, which is the big use of carrots to increase carrot consumption. And that is high levels of discount on healthy foods. So as part of a health promotion program in South Africa, in the UK, in the US, in China, we give up to 20-25% discount through the major retailers on healthy foods. And what has happened? no big surprise, consumption of healthy foods goes up and displaces other products in the basket. It's good news for the consumer. It's good news for the retailer because it attracts people into the store for a whole range of other reasons. It's good for the insurer because the long-term costs are going to be averted, and we know that actuarially. And it's good for the environment because the healthier you eat, the more sustainable the type of diet, because you're dropping water use, greenhouse gas, and land use. And we've quantified this. So we can tell you the percentage change in dietary healthy food and what it translates into in the environment. The question is, what is the equivalent of doing it, say, in a public sector environment? And there are plenty of ways of doing it. We're spending tons of money in this country on subsidizing stuff we want people to eat less of. Imagine transforming that into a subsidy structure or an incentive structure to drop the price of healthy foods, particularly in those parts of the country where you can flag clearly from the county health reports where the need is greatest.
One thing I can add is there's something called the Healthy Food Financing Initiative. I think it's sponsored by the Department of Treasury, and you may want to look at that to see if your community is eligible, and they do have financial support to set up new supermarkets in food deserts, so that's another part of the attention given to the White House on this area. You mentioned the very important topic of advertising, and again, the First Lady convened a White House summit on the effects of advertising by food and beverage companies and how that could be altered to promote healthier consumption. So one example of progress there is Sesame Street has become a very strong partner for the White House and the First Lady, and their characters are now going to be more actively involved in sending messages to kids about healthy food consumption. But I think ultimately it's going to depend on local leadership. I'm hoping that the Let's Move Cities, Towns, Counties model might apply to your area in Detroit, and maybe we can see progress if you bring everybody around the table like David's done in North Carolina.
Well, way in the back. No, wait for the microphone because we're taping.
Is there, can any of you speak to any initiative that's out there to bring physical education back to the schools?
Okay, let me start at the national level there. We have something called the Let's Move Active Schools initiative, and that is trying to make sure that kids reach the recommended physical activity guidelines levels of about 60 minutes of activity a day. And that doesn't mean just PE, but trying to incorporate physical activity into breaks, into recess, into school lessons during the classroom time. And so Let's Move Active Schools now has, I think, about 9,000 schools signed up that have made the commitment to increase physical activity there. We also are moving towards standardizing health through a health risk assessment in schools. And that replaces the old presidential fitness challenge that many of you may remember from decades ago. So this is forward progress. The challenge remains, of course, that how much time spent on physical activity in schools is often a local decision. And so that's where we need colleagues like you to keep sending the message that we need to have schools be places where kids can be active so they can learn better and then learn to be active.
You know, if you hadn't asked that question, I probably would remember the name of the group, because the name of the group, they're actually here today, and some of you can probably help me with it. Playworks. Yes, we have Playworks in Durham. So Playworks, they're in Durham, and this is, I think, where local communities have to be very bold, and I think have to be very direct in terms of doing what we think and we know is right. I call these sort of no-brainers. So we know that kids who are physically active do better academically. It's a no-brainer. We got data that shows it. So we have to then also use some of these no-brainers and help with the incentivizing educators to integrate activity back into the school day. Because from an educator's perspective, and I don't know how many of you work back within schools, there's tremendous pressure because I have to have kids who learn, I have to have kids who are prepared, ready to take a test. I don't have time for PE. I don't have time for organized play on the playground. Well, if you told the educator, you give the educator the documentation, and the statistics would say kids who actually have engaged in more physical activity do better academically, it's almost a no-brainer. It's very similar to what we do in corporate America and what we do just from an adult perspective with employees. I want my employees to go to the gym. I want them to go take a walking lunch because you're going to be much more productive that way. And so I think this is now this communication of what the data says back to schools as we continue to work towards the goal of having children who are academically proficient.
Down here?
Yeah, hi, my name is David Sklar from Academic Medicine. And it's been a great discussion, but there's been one area that I think we've sort of missed out on, and I just wanted to bring it up because I think it's really important, and that's the area of injury prevention. And injury prevention can be motor vehicle, motorcycle, violence prevention. All of those also have a huge impact on health. And I think sometimes it's a topic we sort of shy away from because some of the ways of addressing it have to do with conflicts around individual rights, or at least the way that we think about individual rights. So the question I want to pose to all of you is, how can we have these conversations in our communities about the trade-off between individual rights and, say, motorcycle helmets, or violence prevention, or guns, or safe walking, or whatever it's going to be, because I really think ultimately it's going to have to come from a community decision that we're willing to make safety important for our communities.
Or bike helmets.
Yeah, right.
Yeah, I think you have to start with the data. Compelling stories are good, but unfortunately the compelling stories tend to be about children being kidnapped, and that makes people less willing to walk on the street. If you actually knew the statistics, you'd be much more worried about the stupid slip on the icy sidewalk. And yeah, there's a lot of violent stuff as well.
I'm thrilled for that question because it's only in the recent years that we've seen injury control become more embedded into the public health psyche. And yet some of the best successes are in that field. I was mentioning earlier about occupational health and safety. We've eliminated occupational risks by focusing on what could be done in the workplace. And on a previous panel, I reminded people that when they started doing this, or started calling for seat belts based on the evidence, people said this was a paternalistic policy with dire consequences for our individual freedoms. The result was, as it got implemented, and now it's pretty much implemented, death rates came down dramatically. People saw the benefit and moved ahead. Helmets, again, the evidence is so obvious, yet you have a number of alleged rights-related comments being made. And the same, frankly, is true in gun control. The evidence is so overwhelming, but the evidence is obviously distracted here by some complicated political issues. But I think one still has to keep putting the evidence out. I think we're facing interesting questions inside the workplace where we could learn from the progress made on occupational safety becoming the norm as we're starting to address some issues of mental health, alcohol, substance abuse in the workplace, where it's the safety people who actually see the consequences of failed substance abuse programs first. And that link between safety and injury control and mental health and substance abuse is one that I'm hoping will grow because I think both will benefit. The focus on mental health will benefit and the focus on strengthening some of the basic injury control strategies. I mean, just think of a country like Sweden where their motor vehicle injury goal is zero. And they're not far off. And they've put it into engineering design of cars, of roads, educational awareness, personal engagement, and people are now proud that they are closing in on a zero goal, which would have thought unthinkable many years ago. I can't remember the figures here, but they're obviously way out of sync with that in this country.
We're more likely to solve it with driverless cars, actually, but
Right.
that would be great. It's for real.
Yes.
Did you want to add something?
One way to keep your message alive, it's a very good message, is just to keep emphasizing that injuries and accidents are the leading cause of death in kids.
Yeah.
And so that alone should keep the attention going on that issue. And so thank you for raising it.
In Durham, we have a injury prevention group. They're part of this partnership. And again, these are community members who have come together to say this is important. And when we think about all of the other health-related issues, I mean, we're the city of medicine as well, right? I mean, that's the moniker. Of all the other health-related issues, we have this group focused back on injury. We're very thankful for the group focused back on injury because this has to be a full continuum to just, I think, allow us to hone in on prevention, not just the prevention that we physically see in front of our face.
I think we have time for one more. Right here.
Just to bring back to an earlier conversation, a comment about a prescriptive approach to food benefits. And just a caution, my name is Michel Michon. We work and partner in close to 400 communities of poverty. And we work in neighborhoods where they're in 60 square blocks. The only place somebody can buy food is at a liquor store or a gas station. And imagine in this 60 square blocks where people have no access to public transportation or transportation of any kind, if we restricted what they could spend that food benefit on, they couldn't buy anything. One of the things, so I want to bring to attention Kevin Concannon, who's the Undersecretary of Food and Nutrition Services, had spoken a couple of times about exploring depth of stock rules in grocery stores, convenience stores, and places of food access that would require the retailers to add a much larger percentage of healthy foods to be able to accept the SNAP in the first place. So I just want to caution against penalizing our citizens of poverty with that type of approach until the infrastructure actually is in place so that they have the opportunity to make the healthier food choice. Thank you.
Thank you.
Yeah, I'll say the unpopular thing, that I don't buy that argument. I think it's an argument used by the hunger groups, and I've heard it all the time. I think it's spurious. I think it's against the interests of the poor to encourage a system that doesn't give the opportunities for healthier food to be there. And let me tell you that if you stopped allowing SNAP to be used for a range of products, the same companies would find ways of getting healthier products into those same stores to ensure that they didn't lose out on the income.
I don't disagree with you. We incentivize SNAP purchases to be spent on healthier foods. So we were successful getting $100 million in the Farm Bill to double food stamps at farmers markets. But I really disagree with you because there are places in the country where if you immediately put that restriction in place, those people can't get to the healthy food. And in many cases right now, just because of the way of the obscene subsidies that work that actually cause these highly processed foods to be so inexpensive, when they do find the healthier food choices, they're not as affordable. So it's a much more complicated, it puts the burden on the SNAP consumer who's already at an automatic disadvantage. So I think things like depth of stock and other opportunities to actually change the system before we put the restrictions in place. I'm not saying I'm totally against it, but right now it would really, really hurt people. So I don't buy into the whole hunger thing either. But I'm much more for incentives. We have to be very, very careful.
I'd love to continue this, but alas, we are out of time. So I think if you guys want to continue this, we can continue it after. Thank you so much to our wonderful panel.